Welcome, everybody. We'll get started in just a moment. You're tuning into the Silver Hill Hospital Grand Rounds program. Thanks for joining us, and we'll get started in a moment as people settle into the session.
Can you hear me okay?
Hear you great.
Okay.
Yeah, you hear me okay?
Yeah, perfect.
Great. All right. We will go ahead and get started. Hello, everybody, and welcome. I'm Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital, and we are absolutely delighted to have you join us and privileged to welcome Dr. Andrew Chambers, presenting on the topic, Translational Neuroscience of Addiction Psychiatry from Rats to the 2x4 Model. And I'll have the pleasure of introducing Dr. Chambers in just a moment. But first, some housekeeping. Our next Grand Rounds will take place on June 28th, and we will welcome our own Silver Hill Hospital's Dr. Rocco Murata and our new Chief Clinical Officer, Dr. Mark Russ. Together, they'll talk to us on the neuropsychiatric manifestations of COVID infections and clinical presentations, possible underlying pathophysiologies, and institutional responses. So we very much look forward to welcoming our own in a couple of weeks, and please join us then. Back to today's lecture. As you know, questions remain an important part of our Grand Rounds, and I'll moderate a Q&A discussion with Dr. Chambers at the end of this lecture. This is your opportunity to put forward questions and comments to Dr. Chambers, and you can submit a question at any time during the lecture by using the Q&A box. Enter it with your name, or if you prefer, you can submit it anonymously. A key component of our Grand Rounds series is providing no-cost continuing education credits. And if you wish to receive CME or CEU, please just complete the evaluation survey that we take to heart, and it will automatically show in your browser when we end the webinar. We'll always email a copy of the survey to today's participant as well. One more note on continuing education. We're delighted to inform you that Silver Hill Hospital has been approved by New York State Education Department's State Board for Psychology to provide continuing education for licensed psychologists in New York. Finally, disclosures. No planners of this activity have indicated a relevant financial service with an ACCME-defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And it is now my total great honor to introduce our guest speaker today and my friend, Dr. Andrew Chambers. And I was asked to keep this brief as Andy's got a lot to show us today, but I want to start at least on a small personal note. I first met Dr. Chambers when visiting his wife, Joanna, to do Grand Rounds in Indiana, and we had an instant connection at that time, and it has been a pleasure to know Andy Chambers for many years. He came to do Grand Rounds in person when I was at the University of New Mexico, and his talk was so incredibly well received there that there was instant talk about how do we get him to come to New Mexico to work here. So, and over time, he's been very generous to include that department in research protocols, I know. So I know Andy and his wife, Joanna, to be truly remarkable human beings taking care of patients in remarkable ways with steadfast determination to help those who might not otherwise get care, and teaching at this point decades of learners over the years who I know feel deep gratitude for learning from them. So a bit about Dr. Chambers, who is an associate professor of psychiatry at the Indiana University School of Medicine in Indianapolis. He's a graduate of Centre College, Duke University School of Medicine, and Yale University Psychiatry Residency and Fellowship programs in Neuroscience. He graduated from the Addiction Psychiatry Training Program at IU in 2012 and is now the director of this program. Andy's research has been supported by grants from NARSAD, the American Psychiatric Association, the National Institutes on Drug Abuse, the National Institutes on Alcohol Abuse and Alcoholism, and the Veterans Administration. Andy's basic clinical and neurocomputational research on the neuroscience of addiction in mental illness has been translated into a textbook of addiction, psychiatry, clinical care, and professional training entitled the 2x4 model, a neuroscience-based blueprint for the modern integrated addiction and mental health treatment system, published by Rutledge, New York, 2018. So with that, I could go on, but was asked not to. So I pass the baton over to you, Dr. Chambers. Thank you so much for joining us today. And I'll turn my video off for now and come back when it's question and answer time.
All right. Well, good morning, everybody. And thanks to Silver Hill and Jeff for inviting me in on this opportunity to talk about what we're going to talk about today with the viewers, and both in Connecticut and I understand somewhat nationally. It's really a great way to get a conversation going about the content I've been working on for so long, really my whole career. So I'm really excited to present to you all today. Let's see if I can get this thing to move forward. Oh, there we go. So I'm going to just briefly overview our educational objectives. We're going to talk about addiction, pathogenesis in the brain, and how this disease process interacts bidirectionally with mental illness. We're going to talk about how this new neuroscience of addiction psychiatry translates to an evidence-based model of integrated addiction psychiatry care, exemplified by this new concept called the 2x4 model. And then we're gonna, the final goal is to really recruit interest in becoming part of what I call a revitalized integrated dual diagnosis movement. All right, so the first spot I want to start with is talking about addiction psychiatry. And I know that there are, the audience is multidisciplinary in mental health. You all have contact with all kinds of behavioral health disorders that span the list you see on screen here. And I really want to clarify what addiction psychiatry is, because there's a lot of misunderstanding about what this field is. And that's important to establish that for this talk, that it's not about being good at treating one disorder like opiate addiction. In fact, addiction psychiatry is very broad. So why do we, meaning mental health and psychiatry, and our patients especially, need addiction psychiatry to get much bigger? And if you look at what I have on screen here, just a list of some of the top forms of mental illness that we encounter, a list of the top forms of substance use disorders. We all know that these disorders do not occur in isolation. In fact, patients have many different and various comorbid combinations of these disorders, and that's what we routinely see. And in fact, something like a patient who presents strictly with opioid addiction or strictly with alcohol addiction, that's actually a quite rare presentation to only have one diagnosis. And in fact, when you look at the behavioral health treatment spectrum, we actually have the capacity for there to be mathematically over 2 million different comorbid combinations of these very common disorders. And most patients have 2 or more of these on both sides. So really what we're talking about is a field that's focused not just on addiction, but the entire behavioral health spectrum of mental illness in combination with addiction. If you can look on screen at this epidemiological chart at the top, and what I'm doing here is I'm showing rates of the 3 major forms of addiction, meaning alcohol, nicotine, and illicit drugs, across the general population and the major mental illnesses that we treat. And what you can see is 2 major take-home concepts. One is that addiction involving all of these classes of drugs is greatly amplified and occurs in much greater frequency across the entire mental illness spectrum. There's no monopoly or a specific relationship between any one addiction and any one mental illness. So we're really talking about a population of patients in behavioral health in which dual diagnosis, meaning a patient who has both mental illness and addiction, is actually the majority of all of our patients. So you're on a minority side if you only have mental illness without some kind of addiction, and similarly, some kind of addiction without a major mental illness. So we're talking about this big group in the middle that are the majority of our patients. They're also the most medically ill or vulnerable. They're the most likely to be homeless, most likely to be criminalized and incarcerated, least adequately studied, least adequately treated, most likely to die prematurely. So, what are we to do in psychiatry and behavioral health to address this? To treat all this sickness with greatest impact, psychiatrists really need more addiction psychiatry training. And what does that mean? It means increasing your acumen in diagnostic and interviewing skills, advancing your expertise in both pharmacology and psychotherapy, because both are bedrock treatments for both mental illness and addiction. And on top of that, greater skills and team leadership in the integration of diagnostic work, medical management, and psychotherapies for the entire spectrum of patients. So that's really, what I want to summarize. What is addiction psychiatry? It's actually expertise in dual diagnosis comorbidity. It's actually not, it's kind of a misnomer to view addiction psychiatry as a subspecialty, because actually it's more general than general psychiatry. It equips psychiatry with more tools to treat a broader array of patients. So moving forward with that, most of you all will know that this is not unique to addiction psychiatry. And the concept of integrated dual diagnosis treatment, also known as IDDT, this movement has been around for decades, since the late 1980s and mid 2000s. And we've known for a long time that when we have these siloed systems of care that we currently have and have had forever, of insisting on separating research, treatment, and education in mental illness and addiction into separate silos, we end up with a lot of real problems in behavioral health. Our care is not efficient of time or cost. It's less effective. It ends up being more chaotic, and in some ways even more harmful when it's not integrated. And largely, there's a breakdown in continuity of care when one system is not competent at treating both addiction and mental illness. So we've known this forever, many decades, and I'm just pointing out some of the leaders on this movement. I mean, you look at Bob Drake at Dartmouth, who published this paper in the year 2000 called Dual Diagnosis, 15 Years of Progress. If you look at this little box on the right, this is a paper published in Biological Psychiatry in 2004. And, you see a list of names that basically are all the research leaders in psychiatry at that time, including the leaders of NIH, behavioral health institutes, and they're all saying we have to merge addiction and mental health care. Well, what happened to the integrated dual diagnosis treatment movement? It never happened. And why is that? Well, we've been through a lot over the last 20 years, since the year 2000. So this is a answer that involves multiple components, but I just do want to point out three pieces of why this never happened. Number one is that stigma against addiction is alive and well in society, healthcare, and psychiatry. We have to confront that reality. Number two is that there was originally, in the original integrated dual diagnosis treatment movement, a lack of understanding that physician engagement is key. You can't just have a system become integrated. You have to get the doctors on board. And that means addiction psychiatry, which really was not part of this movement. It was not really included or mainstreamed as a major part of integrated dual diagnosis treatment. So finally, there really has not been an integrated neuroscience of addiction psychiatry. What I mean by that is, what do we know about the brain that makes the need for integrated mental health and addiction care so important for us to advance? So, here is kind of what I would say about the integrated neuroscience of addiction psychiatry and how important it is for us to understand how the brain mechanisms that that link mental illness and addiction can explain so much clinically and drive what we need to do in terms of training and clinical services. You know, first of all, the only way we're really going to defeat stigma is through understanding addiction as a genuine disease of the brain with neurobiological risks. Secondly, this neuroscience should be able to explain what causes all this comorbidity, and also what I would say is a phenomenon of diagnostic drifting. Now, what do I mean by that? You know, what I'm saying is what is happening in the brain that could cause so much overlap between addiction and mental illness, and also realize that patients are not stuck in one of these three categories. They routinely migrate across these categories. And how do we understand why and how that happens through one sort of unified neuroscience? Finally, you know, again, if we have this neuroscience in hand, it really should motivate and drive a really big change in how we train and do research and provide clinical services in psychiatry, in which addiction psychiatry is no longer this marginalized sideshow, but really becomes the core where many, many more of us are involved in addiction psychiatry. Now, what I'm proposing here is a new system where you have a clinic that's capable of treating any combination of mental illness, dual diagnosis, or addiction across the whole spectrum, and having a system of clinics across the entire, and hospitals across the entire United States. So no matter where the patient goes, they know they can get integrated treatment by treatment teams that are going to be able to provide the full spectrum of services. So I want to shift a second into how did I and others become involved in this integrated neuroscience of addiction psychiatry. So my journey into this started about 20 years ago, and it really started with this publication I did with some folks at Yale, John Crystal, David Self. And what we're asking here is, let's forget that there's a whole separate literature about schizophrenia and addiction, or mental illness and addictionology, and there's siloed science areas. And let's ask the question, what is happening in the brains of people with mental illness that may bring on or accelerate addiction disease? A little bit of this new approach is an overturning of the old mythology of self-medication. And the reason I say that is like this. Think about HIV can give rise to cancer and certain infections, right? So you have one underlying problem, HIV, that gives rise to two secondary syndromes and biologies. Now, we don't think of people with HIV who are infected trying to develop Kaposi sarcoma as a way to medicate their infection. We think of an underlying biology that gives rise to two separate or integrated pathologies in parallel. So the good news about this new science is that you can actually generalize it and begin to explain the entire dual diagnosis spectrum. There are going to be different environmental histories that patients have, different genetics that come together, but in different ways, they may channel into a common neurodevelopmental neurocircuitry pathway that gives rise to this spectrum of psychiatric syndromes and addiction vulnerability. I want to introduce my son here. This is Gabe, who at this time was age 5. And we're at a Colts game. Now my son is 20, but I asked him back when he was age 5 to define a disaster. I wanted to see how he would, what he understood about the word disaster. And he gave such a cute answer. His answer was something really amazing that happens that nobody wants. And I thought that was such an elegant way to express what a disaster is. And of course, you know, dual diagnosis, mental illness, addiction, these are real disasters, but they're integrated problems. You know, it's kind of like I'm using an atomic bomb here to represent another kind of disaster, but there's an analogy here that's worth it. And that is that, you know, you can have different types of atomic bombs that lean more toward the heat and the blast, or more toward the radiation, depending on how you put these ingredients together of the explosive force of conventional explosives versus dense elements that create the chain reaction. And I want to propose to you all that this is really what we are seeing. We are seeing variants of a addiction and mental illness spectrum that has a common biology and a common engineering that reflects brain architecture. So how do we get at that better? You know, here's a map of all the major mental illnesses on the left, and here are all the major addictions. And how could that be plausible that these diseases, which, you know, we want to treat as separate, are so integrated? Well, this is how the plausibility of that comes about. When you look at how the brain is built and designed, all the major circuits that mediate all these major mental illnesses, and I've color-coded those circuits as blue, those circuits are tightly integrated and wired into the red circuits, which mediate motivation and drug reinforcement. They are not separate, they are integrated. And when one brain is connected to itself, you really can't have one disease that can exist without the other. One leads to the other. So we have this idea about how it can occur, but we need to prove it. And the way you have to prove it is in animal models, because it's not ethical to design causal studies that involve human beings to test this integrated hypothesis. So that's really what I've done. And a lot of this work that started for me about 20 years ago has really been based on this animal model of schizophrenia that was developed by Daniel Weinberger at the NIMH in DC. And this is really an astonishingly accurate animal model of schizophrenia that you produce in rats. And what's amazing about this model is that it basically reproduces the entire clinical phenomenology, histopathology, neuroimaging features of schizophrenia. It reproduces the psychopharmacology of the disease and even the peri-adolescent developmental trajectory. And it does that based on a neurocircuit intervention that you do in baby rats by damaging an area of the brain called the ventral hippocampus, which produces this entire syndrome. And you can see that this intervention in the rats, you know, obviously impacts not only the circuits that mediate mental illness, but it's going to have downstream effects on motivational circuits that involve addiction. So what you can do with this kind of animal model of mental illness is actually create a dual diagnosis spectrum population. You can give these animals cocaine, alcohol, nicotine, other drugs versus placebo, and generate really what we see in the clinic. You know, some patients have more mental illness, some patients have more addiction, some patients have a whole lot of both. So you can create this dual diagnosis spectrum in the animal model and then do all kinds of interesting testing to explore how the mental illness and addiction are interrelated, both on a phenotypic level and a neurobiological level. So I'm going to move into showing you all how that looks. So here is a study where we use NVHL rats, that's the schizophrenia model rat, and we allow these rats versus healthy rats to self-administer cocaine. And what you can see is that week after week in the dark triangles, the mentally ill rats are right off the bat avidly self-administering cocaine at much higher levels than control animals. And this overuse of the drug or acquisition of the addiction phenotype accelerates as time goes on to a greater extent in the mentally ill rats. And we can also look at other traits of this addiction phenotype and mental illness. For example, in the NVHL rats, they showed a much greater incidence of actually using so much cocaine that they would overdose. And we had to cut them off from the drug because they were so vulnerable to overdose. And this is exactly what we see in human beings. Secondly, once we cut them off from access to cocaine, the mentally ill rats specifically continue to work to pursue the drug. So they have a hard time letting go of that drug access even when it's been removed. So what's really crucial to know about this data is this cocaine is not a medicine for this mental illness that these rats have. The cocaine also worsens the mental illness. So it's not self-medication that we're seeing. What we're seeing is the addiction the addiction being driven by the mental illness, and at the same time, the mental illness being worsened by the addiction. So we and others have gone on to show that this is not drug specific, just like what I showed you in one of the earlier slides. This comorbidity between the mental illness circuit problem is true for multiple types of addictions, including cocaine, methamphetamines, alcohol, and nicotine. And the same things we're seeing in the rats map to the human epidemiology. So another interesting finding we found is the way in which, this new picture emerging that mental illness is kind of like, a celestial body of great gravitational pull like Jupiter that tries to pull in other brain pathologies into it, like cocaine addiction, nicotine, and alcohol. This explains why people with mental illness so often have multiple addictions. This is actually a study we published that shows that these mentally ill rats will also self-administer nicotine and alcohol simultaneously at greater rates compared to healthy rats. We can also explain this addiction vulnerability in this kind of animal modeling across different types of mental illness models. Just like in humans, there are many forms of mental illness with different etiological ingredients. Well, the same is true in the animal models. And you can create mental illness in many different ways with many types of lesions or experiential traumas, environmental deprivation, etc. And what you end up seeing is this collective effect of changing the addiction threshold, the disease process of drug addiction across the board. So here we've kind of used this animal modeling to explain all this convergence of environmental events, neurocircuitry perturbations that lead to this common pathway that sets individuals up for mental illness and addiction. And what you can see even is that in one of our latest studies is we were able to combine the NVHL model with environmental effects, environmental deprivation. So this is kind of like a 2x2 design where we've created a population that's multifactorial in terms of mental illness etaology, but these different factors can combine, say, in the way genetics and environmental experiences would, to create a super phenotype of mental illness comorbidity. And so what we've also demonstrated is the more genetic or not genetic, but the more neurocircuitry based and environmental loading the individual has into this mental illness pathology, that is going to be proportional to their addiction risk. And again, that's what we see in the literature across the board. The more mentally ill a person has in general, the more vulnerable and more likely they're going to acquire a addiction disease. And this is exactly what we see in this kind of animal modeling, where the mental illness phenotype that gets worse with the compounding of etiological factors for mental illness actually translates into a compounding worsening of addiction disease vulnerability. So what we've done in the last few years is really reframe this whole area of neuroscience and try to translate it into a unified approach, not only to the integrated dual diagnosis treatment movement, but also the field of addiction psychiatry. And I was able to publish a book in 2018 called The 2x4 Model that really integrates and translates all this science and clinical research and service delivery effort into one kind of coherent framework called in this textbook. Now, I use this textbook as the core textbook for my addiction psychiatry fellowship, but HRSA also got a hold of this textbook, and they were through a new funding mechanism that's trying to build up our workforces in addiction psychiatry. They actually funded a major project that I'm going to tell you more about here in just a second, called the We 2x4 Addiction Psychiatry Network. I'll tell you more about this project, but first I want to transition into a film that we've made that's part of this project. Now, this film I'm going to show you is all new. You all are one of the first audiences that has seen this movie. It is a digital animated film that we designed to illustrate the full neuropathology and disease process of drug addiction and its interrelation with mental illness. And our mission in creating this film was to try to provide as many professionals as possible a clear understanding of what addiction truly is and how it's so tightly related with mental illness. And if we get enough people to see this film, which is entirely science-based, we may actually be able to change our field. So I'm going to pause this screen share just for one can. I hope everyone can see the slide we just left off before the movie. Just one clarification for everybody about, kind of defining exactly what is the 2x4 model. Why do we call it that? So what the 2x4 model is a integration of services and expertise that addresses both addiction and mental illness. So it's the idea of completely rejecting the siloed care model and saying that every clinic needs to be fully capable of treating mental illness or addiction in whatever way it presents, in whatever combination it may present in. So that's why we say it's on the illness dimension, there are two dimensions, mental illness and addiction. Now, across these vertical components, we have to define exactly what tools should be available. Otherwise, people don't have the full complement of the essential tools to do this kind of integrated care. So there really are four components, four vertical components. You have to have a certain set of diagnostic tools, a certain complement of psychotherapies that involves individual and group psychotherapy, as well as the full array of expertise and delivery of medications for both mental illness and drug addiction. And then when you have this integrated one team that's fully capable of treating this whole spectrum of service components, that team should be able to communicate coherently to outside stakeholders, insurance companies, other medical professionals, the criminal justice system in one unified voice to protect the patient. In a split care model, no one's really in charge of the patient. We just have a system that is selling products to patients with mental illness. We need to get away from a product delivery system to a coherent mental health addiction treatment system. So lots of people to thank for this, the work I've done on this over the years and the funding streams that I've mentioned on the left. But now the best part of our hour and a half is next. So I just want to entertain any questions that may come up, and I'll get out of our slide deck and put us on back to screen share.
Dr. Chambers, that was just amazing. I think you have a new calling here in actually making complex science easy to understand. So thank you for that. It was beautiful talk and beautiful video, and just an honor to be one of the first audiences, I think, to get to see your work and all that you've put together, representing the work of your lifetime in getting care to patients. It's very moving, actually, to hear you present that and to see the film. I was wondering, we have some questions in the chat, and I'll start us off just with the question of can you talk a little bit about kind of some ideal clinics that you know of that are doing this correctly, and have we in certain areas progressed, and what those look like?
So absolutely. So as part of my fellowship in addiction psychiatry and my early years as director, we built this clinic. And that actually happened before I wrote the book. So the book is a description of the clinic we built that accomplishes this. And like I said, a lot of it is it's been heavily informed by the integrated dual diagnosis treatment model. It's not really reinventing something that hasn't been around. It's just we implemented it. And once we implement it, what the other thing we needed to do is concretely describe what are the essential elements you have to qualify. And the reason we did that is there are lots of systems out in the country that claim to be dual diagnosis capable, but they don't really have all the ingredients. And so if you're going to say you're dual diagnosis capable, there really has to be some kind of standard. And so in writing the book and creating these clinics, we wanted to ask, what are the bare minimum ingredients and kind of perspective training of the staffing and ways you provide care that make this real and replicable across different clinics. And so the good news is it's not hard. I mean, I don't know if it's good news or heartbreaking, right? Because you don't have to do that much more to make this real. And there are barriers. There are plenty of barriers out there. Funding streams is a barrier for anything behavioral health, right? No one wants to pay for it, even though it's the most important public health mission that exists. There are financing barriers, and there's also stigma. There's people don't want to change on the treatment side. There's the mythology of self-medication, which is really a barrier against integrated treatment. There still are barriers. There's misunderstandings about drug testing and how you do that. There are people who feel like, well, I don't want to treat addiction because it's just not my responsibility, and I don't like those people. That kind of stigma. And then on the addiction side, people who don't feel like they need to be expert in mental illness. So there are all these kind of cultural barriers, but they're really not that hard to overcome. And there's lots of ways for psychiatrists to get involved in this. It's not just doing an addiction psychiatry fellowship at the moment. You can, all of us can, who are psychiatrists, can pursue still addiction medicine certification where, it's not as good as a fellowship, but it gets you started. And if you can get around someone who's fellowship trained and knows how to throw all this in, it's not that hard to do. So I think that we're not far away from making this happen. I mean, I read a paper the other day where they were calling for this 30 years ago to make all of our community mental health centers fully dual diagnosis capable. And they were saying this is where you should do it, because you can't teach family medicine and internal medicine 1 year how to do psychiatry. You have to start this within psychiatry. Psychiatry is the natural home of the best of addictionology. And so it's not that much further to go to make this happen, but we have to overcome some barriers. And, I would say, I'm going to say something that, a lot of people may not agree with or could be disturbing, but we should not have 3 separate institutes. This is one of the major problems. The fact that NIAAA and NIDA and NIMH are separate creates all kinds of downstream silos and causes tremendous damage to academic psychiatry, incredible damage, which harms our patients. These silos and failure to understand there's a universality and training that should swing both ways.
Great. Let me thank you for that. Let me turn to some of the questions. Helen Vanderlyn asked, can you speak, Dr. Chambers, to the added layer of challenge and disparities in diagnosis and treatment in marginalized populations?
Absolutely. I think this gets back to a couple of dynamics, right, that are historic, that are very relevant to that question. One is deinstitutionalization. The second is the war on drugs. So let me reframe that. When deinstitutionalization happened, we did not know that mentally ill people were biologically, involuntarily vulnerable to drug addiction. We had no clue that was true. So we closed all of our sheltered living, all of our therapeutic living environments. We shut down these hospitals, forced them out in the community, and before long, they end up criminalized and homeless. Now, again, the war on drugs, the idea of the federal government and state governments that we are going to incarcerate our way out of this. Well, guess what? That doesn't work. And secondly, because mental illness and drug addiction are interlinked biologically and involuntarily, when you criminalize drug addiction, you criminalize mental illness. Now you have a situation where in the United States, we have criminalized diseases that psychiatry treats. That gives the insurance industry and the rest of our healthcare system one beautiful excuse to withhold insurance support for treating these diseases. And they get the bonus that when these diseases are not treated, they make lots of money treating the medical damage that these diseases cause. That's where we're at. And, how long do we talk in the media about the crisis of mental illness and addiction and homelessness and the disgrace of public mass homelessness and not move in this direction? How long do we sit here and watch this? I mean, that's kind of where I'm at with it to address that question.
Yes, right on with that. Let me jump to another question here. There has been some, Kathleen Murphy asked, there's been some research on neurogenesis, the notion of the birth of stem cells that may occur throughout one's lifetime. Is neurogenesis a possible model for treatment with addiction and reversing the effects of addiction?
Absolutely, 100%. So, as I'm glad that question was asked, because it shows that, we included that content in our film.
Right.
And so here's what's super interesting about neurogenesis. Again, it's another convergence point. Just as the nucleus accumbens is, so is the hippocampus for addiction and mental illness. And so, what we know is that there are conditions that enhance neurogenesis in the brain, and there are conditions that suppress it. And, there are lots, environmental enrichment enhances it. Certain psychiatric treatments enhance it. On the other hand, addictive drugs almost across the board suppress it, alcohol, opiates, evidence not as strong for stimulants, but there. And so addiction, when you have addiction, you suppress it. Good psychiatric treatments support it. And so I think, moving into the future, what we really need to be talking about are treatments that are integrative, meaning one treatment that we look to potentially treating both mental illness and addiction in one throw. And that is what we really need to be aiming for if we truly believe the diseases are integrated. And of course, we're not doing that, right? Because we have NIH and NIDA and NIMH and NIAAA completely siloed off. You can't get a grant to do this kind of research. You can't get federal grants to study what's real, in terms of this comorbidity. But we need to be funding integrated treatments. And what I mean is, again, any treatment, maybe it's stem cell placement into the hippocampus. Maybe it's a combination of a psychotherapy and a medication that we believe could treat both a type of mental illness and an addiction. But, if we want to move into that future, we have to have clinics that are capable of treating both mental illness and addiction. You can't have science that doesn't reflect clinical capability as a foundation.
Yeah, thank you. Thank you for that. So Anita Mathers asks, in addition to mental illness and addiction, how do intellectual disabilities and ASD further impact functioning, and how should treatment integrate this aspect for positive outcomes in this population?
ASD, is there ASD, that acronym? Can I get
autism spectrum
disorder? Yeah. So great question. So here's what's there's some neuroscience to address in that question. So cognitive impairment that exists outside of the major mental illnesses, if you categorize it that way, different cognitive disorders and autism spectrum, that neuroscience is a little different than the other traditional mental illnesses I've gone over. And in fact, what we see is that those types of psychiatric illness, cognitive illnesses that are on the ASD cognitive disorder spectrum, like Down syndrome, I'm including, for example, those illnesses are not really as liable to addiction as we see in the other major mental illnesses. So they're a little bit of a different category. Nevertheless, it can still happen. And, I think that obviously we need to be training our teams of doctors, nurses, and therapists to be working together, no matter which of these illnesses that we're treating. And understanding that the etiologies of these conditions are not really as discrete as the DSM-4 would like us to believe, or that or the insurance companies would like us to believe. They're not discrete. They're continuum disorders. They're admixed. So we got to stop building treatment that pretends they're discrete, because that's not reality. We have to build care and expertise that reflects the reality. Otherwise, we're not science-based. And so I think obviously there are special, I'm not trying to be anti-specialist, but I am trying to say that there's definitely room for expertise that goes across these boundaries within mental health. That includes ASD and cognitive disorders. Yeah.
Great. Our President Dr. Andrew Gerber says, wonderful and much needed talk. Is dual diagnosis the right term when really there are many more than two diagnoses in most cases? Is there a better language we could be teaching our students, patients, and families? Patients and families are also confused when they're told they have multiple diagnoses. Isn't that more a failure of our own diagnostic system and less about the true number of diagnoses?
Totally wonderful question. That's right on. I struggle with the term dual diagnosis, just as Dr. Gerber's suggesting, because it's not dual diagnosis, right? It's not like nicotine and schizophrenia. That's rare. It's usually schizophrenia, nicotine, and one or two other things. It's actually polydiagnosis. So even the term dual diagnosis is problematic. And there are other terms out there. There's co-occurring disorders, right? But the limitation with even the words co-occurring and dual is that it almost implies they just happen to come together as coincidence. They're not really linked, and that's not true either. So we have all kinds of problems with our language that propagates misunderstanding. And I just don't know. Once a terminology gets baked in, it's hard enough to get science out there and get people to see it from a different way. But when you start trying to change the lexicon, that's another problem and another political battle. And so at some point we got to, I think, focus on changing what we do rather than changing our words, right? Words can be a ruse to not really do anything. So, it kind of gets into, I know that, people talk about trying to get rid of the word addiction because it's stigmatizing. And my view on it is the word's not the problem. The word's we don't treat it. In fact, the medical system has been pretty busy causing it for profit for a couple decades. So not treating it. So let's change what we do, and maybe the words will come later. But I think Dr. Gerber's point's totally correct. There's not great words that exist right now to describe this.
Thanks, Andy.
Yeah.
Dr. Murata has multiple comments in the chat. Dr. Murata, who will be up here in a couple of weeks. He says, first off, Dr. Chambers, thank you so much for all your efforts, and reminds us that we at Silver Hill do have a hospital that treats both mental illness and as well as addiction. And then has some questions here. It says, and comments, in our work with schizophrenia, we have seen that we must engage the use of drugs in our patients and also work on reintegration into supportive social environments. In terms of specific pharmacologic interventions, we found clozapine to help in a major way in helping with sobriety. Mm-hmm. We have also used oxytocin to help with treatment of negative symptoms, and also we believe with protecting the hippocampus so that our patients can move from a position of being caught in a vicious cycle of decline to a virtuous cycle of a better life. Have you found any particular pharmacologic interventions helpful?
Awesome question. And first of all, I have been aware that Silver Hill is probably a leader on a hospital level I'm glad to know that Silver Hill is a leader in this. And so I knew that walking into it that I would not be. I'm preaching a little bit to the choir in terms of the Silver Hill community, and I've referred patients to Silver Hill, kind of knowing this, even from as far away as Indiana. So I know that we're in kind here in our thoughts about it. So the other thing is, the treatments that were suggested there, Clozaril, absolutely. Dr. Green, original chairman at Dartmouth, who's passed away, he's done a lot of work with Clozaril and dual diagnosis. The data is very compelling. There's Wellbutrin, right? Wellbutrin is the bona fide dual diagnosis treatment drug. Parsimonious, treats a mental illness and addiction. Oxytocin absolutely has promise. The problem is, Dr. Green and others were talking about Clozaril 20 years ago. It's not implemented widely. We're talking about even addiction treatments with already available FDA approved drugs or evidence-based are not getting implemented. Our infrastructure in behavioral health is a disaster. It's fragmented. We're not training enough well-trained people at the psychiatric level, at the nursing, the therapy level. We're not reimbursing it. So of course, all this science can't get translated, and we don't have the infrastructure to bring that translation quicker. If we had a system of integrated dual diagnosis clinics, that all kind of approach this the same way, you could, in a heartbeat, test 3 or 4 multi-site clinical trials, because they all have the same rating scales. They all have the same expertise. They don't discriminate against patients because they have an addiction or a mental illness in their clinical trials. And we could force amplify so quick to bring these ideas and test them on a big scale, get them FDA approved, and really create pressure to create a national system of hospitals and addiction psychiatry clinics that are interlinked and collaborative. That's kind of where we need to move.
Oh, so good. I'm getting behind on the many questions here. Maybe I'll be able to send them to you, Annie, for an answer. But quickly here, and some of these are very big questions. Gary Steck says you mentioned therapies. Which models and approaches do you suggest?
Oh, in terms of psychotherapies?
Yeah.
Well, we have to stick to the evidence base. And the good news is, oh my gosh, there's loads of evidence for therapies, and many of them are flexible to both addiction and mental illness, right? And there are some therapies that are evidence-based that are specifically for dual diagnosis, what else is really exciting right now in neuroscience? And you know this, Jeff, this is a topic that's happening with the American Academy of Psychodynamic Psychiatry and Psychoanalysis, that, oh my gosh, you all, the neuroscience to understand how psychotherapy works and how important it is, and that we should not be viewing it as a non-biological treatment. That's a fallacy. The neuroscience that justifies the need for psychotherapy is becoming richer by the day, and it's really moving us in a direction we've needed to go for a long time. So, I think about core ingredients. The clinic has to have the ability to do both individual and groups. If you don't have those two basic formats, you don't have the puzzle. You're not quite competent at this. You have to have both. Secondly, what are the schools of psychotherapy that should be implemented? We talk about the core ones, which I think are the most important. Supportive psychotherapy, CBT approaches, motivational enhancement therapy, and motivational interviewing approaches absolutely are required. And the team members need to be able to blend them eclectically. This requires skill and training, and we've got to support that. But there are other, therapies that are coming around that are, really strongly evidence-based on the neuroscience and clinical level. Circle of security. There are certain therapies that really zone in on trauma and addiction. There are therapies that, do better with attachment, trying to fortify attachment. All this stuff is so critical to both addiction and mental illness. So those are that's just a brief list of some of those. Yeah.
Thanks, Andy. number of questions continues to grow here. I'm not going to be able to get them all. And this next one I'm going to give to you. You have 10 seconds to answer.
Okay.
Dr. Murata asks, I've always felt that craving is a function of availability. How do we deal with the easy availability of dangerous substances in our culture? In 10 seconds, Dr. Chamber, what do we do?
Well, you're right. Craving is trigger cued, right? So a trigger, it's not entirely, but in part trigger cued. We're not going to get rid of availability. That game is game over. Game over. The internet, the liquor store, Walmart, addictive drugs are ubiquitous. That's not going to turn around unless we want to turn into a totalitarian government, which I don't want that either. We can't go back to prohibition. So that game's over. What we got to do is pursue superior treatment for people who get into trouble. We got to stop incarcerating and outlawing and using the criminal justice system to do healthcare because they're not competent and they have their own problems, right? So that would be my answer is we need better addiction psychiatry and, we need better treatment. Most of us probably on this call drink alcohol. Most of us don't end up with a disease with drinking. So I think you're right. Access and availability, it's everywhere, but we really need to think about taking care of each other better so fewer of us get into this trouble and more of us can get out of it when it occurs.
So Dr. Chambers, thank you so much. Thank you for sharing your wisdom, your new video. I now can more coherently talk about the nucleus accumbens and hippocampus and their relationship to addiction and what happens. And so to be able to do that so quickly in our learning session, thank you for providing that for us. You're an A+ instructor and researcher and clinician, and it's just so great to see you. So great to see you. You
too, and thanks to everybody. The questions were awesome. I'm sorry we can't do this for a day because this is what the fun part is, right? Thinking through all this. So thank you.
Yeah. Well, we may be able to set that up. We'll talk about that a little bit. Okay.
Okay.
So
take care.
Thank you, everybody. On the call, as we said before, the link for continuing education is there in the chat, and we will email that to you as well. Please complete the evaluation survey that will automatically show in the browser as the webinar ends. And this is farewell and goodbye for a couple of weeks. So see you in 2 weeks. And thanks for joining today.